Wonderful. I'm sharing my screen. There were a few questions which were sent to me. So we will start the meeting. And these are some of the questions which were told. Okay. Now, the first question was there were some doubts on ortho K, and there were some doubts on peripheral refraction, and there were some doubts regarding how to use the myopia control glasses. Now, with ortho K, the first and foremost thing is whether we can use ortho K patients and adult patients also. Well, in Western countries, they have been using ortho K for adult patients. So the design of ortho K where we control myopia is slightly different from the design of ortho K, which does not need to be for myopia control. So very correct. Ortho K is very much used for non-progressive myopia. And I had recently, I went to a myopia conference and I saw that, there are patients, there are some optometrists whose kids were wearing ortho K since last 18 years and 20 years. So yes, there have been patients who have been using ortho K for a very long time. And ortho K has been in vogue almost since last 15 to 16 years. Myopia control ortho K are slightly different because in myopia control ortho K lenses, we want to create a peripheral ring which behaves like, a plus 3.5 or plus 5 or plus 6 lens. And that is what creates a myopic defocus instead of the peripheral hyperopic defocus. So the theory of ortho K as to how ortho K acts is very similar to myopia control glasses. Now, to assess the progression of refraction or axial length in ortho K, for axial length, you need not remove ortho K because the cornea may become flat, but the change in that will be very minimal. So axial length changes you can assess little bit here and there, you can know. But if you want to see the refraction, at least a month is what is recommended. But if you are going to do a cycloplegic refraction, at least 15 to 20 days, you have to tell the patient not to wear ortho K lenses. Now, the problem is that once you start these ortho K lenses, it becomes very difficult to bring out the patient from ortho K lenses because, it is like magic. It is like the patient is constantly hooked to ortho K because if he doesn't wear ortho K, he has to wear glasses, very similar to refractive surgery. So it's like once you do a refractive surgery, it becomes very difficult to tell the patient that they have to wear glasses again. And when they don't use ortho K for a couple of days, the refraction becomes very unpredictable because cornea will take its normal shape, but it takes some time. If you have used ortho K for almost 6 months or 1 year, then the cornea taking its shape becomes little bit difficult. So that is regarding ortho K. Can ortho K be used in pre-myopes? Now, pre-myopes actually don't have much power. So, in terms of peripheral refraction also, the glasses which are now available from Essilor or from MyoSmart or Hoya, they are also available for small powers. Yes, they do have plano halt lenses, but as I am talking about ortho K, it will be very difficult to convince the patient that what ortho K is doing. So they are using ortho K for preventing the progression of myopia, but you cannot flatten the cornea because then you will become hypermetropic. So if there is a very small power like 0.5 or 0.75, yes, you can use ortho K, but that is a very minimal power. Fitting of ortho K lenses should. Yeah. Dr. Aval, there is a question.
No, sorry, sir.
It's okay. So now, when should we recheck? After how much duration it should be rechecked? Obviously, you have to check it once. I think there are two aspects to this particular question. You can fit ortho K, put fluorescent, and check the fitting. If that is the question, you have to check it immediately when you are doing the fitting. So you do it with trial lenses, then you order the lenses. When the lenses come, you call the patient again, fit the lens and check the fitting. Then you have to check it again after a month to see whether, patient is comfortable or not, what is the visual acuity. Normally, we tend to call the patient after a week itself because we want to make sure that, he's comfortable and his glass power is actually gone. So sometimes, they will come with ortho-K lenses. Sometimes they even forget ortho-K lenses because they have worn those lenses overnight. Now, can poor fit of ortho-K lenses be responsible for progression of myopia despite regular use of ortho-K? Now, if the ortho-K lens fitting is not good, what will happen is patient will never be comfortable, because if there is a upper rim which is gone, or lower rim, if there is a frowning or a smiley fit, the problem is that patient will have irregular astigmatism. Patient will never be happy. So you have to call the patient again after 1 week. Of course, it could be responsible for progression of myopia, but more importantly, patient himself or herself will not be very comfortable with those lenses. So patient is going to come back to you saying that, I am not able to see clearly. And that itself will tell you whether the fit of ortho-K is proper or not. If the fit is proper, then his vision will definitely be good vision. And if his vision is good, it means the fit has to be really good. For peripheral refraction, the question that nasal temporal asymmetry in peripheral refraction is already described. Now, how much of it is significant? Now, nasal temporal asymmetry in peripheral refraction is only published from LVP. Nowhere else it has been much discussed or published. The question, does it change our management? It doesn't change our management at all. Low concentration atropine does not get affected with peripheral refraction. So we are not really thinking about starting or stopping low concentration atropine depending on nasal or temporal asymmetry. There have been patients who are on DIMS or HALT lenses, and they don't really have peripheral hyperopic refraction. So even those patients do work out to be good. That is what is published. So nasal temporal asymmetry has been reported in myopic patients. The fact that whether these patients progress or not has not been seen properly. Which patients will progress, which will not progress, mainly is not based on nasotemporal asymmetry or whether there is a peripheral hyperopic refraction or not. But yes, if you have peripheral hyperopic refraction, these glasses would definitely work. Peripheral refraction should be done after cycloplegia. Yes, you should do it after dilatation so that it becomes easier for you, number one. Number two, if patient is accommodating when he's looking towards left or right, it would be difficult for you to find out. You can do with or without glasses. See, peripheral refraction, one thing we have to understand is that this peripheral refraction is relative to central refraction. So you do it with glasses, you do it without glasses, whatever is the central refraction, when you are looking straight ahead, whatever is the refraction, if the peripheral refraction is hyperopic to that, then it is significant. Any distance, if it is the central refraction is with accommodative target, peripheral refraction is also with accommodative target. So peripheral refraction does not have any importance separately. Peripheral refraction has an importance when you compare it with the central refraction and it is on the hyperopic side, then it is peripheral hyperopic refraction. So peripheral hyperopic refraction is mainly truly about comparison between central and peripheral. Whether it should be checked in horizontal meridian or vertical, or does any meridian work? Now, the point is that, normally it is checked in horizontal meridian and it is a given that it will be similar, but it may not be similar, not at all necessarily that it will be similar. Now, checking peripheral refraction in vertical meridian is not so easy, at least on the open field autorefractor. Why? Because the moment you look down, your lid will cover the upper part and it will be difficult for the autoref to do it. So you have to, you have to elevate the lid. That is number one. Number two, beyond a certain point, it becomes very difficult when the patient is putting his neck on the chin rest to look down at least 30 degrees. So peripheral refraction normally for all practical purpose, we do it in horizontal meridian. Whether it should be done on the research basis, we should do it in up gaze also, down gaze also, and we can easily do it. You just have to tell the patient to look up and look down, 20 degrees up, 20 degrees down, and that is fine. So you can do it for the sake of clinical purpose, for the sake of myopia control. We normally do it nasal and temporal because that is easier. Not that you should not do in vertical meridian, but it would be difficult to calculate the peripheral refraction in up gaze and down gaze. That is why we have reduced our work and we mainly deal in nasal and temporal side. Now, is the neutralizing lens in peripheral refraction should be in the line of visual axis or the examiner? See, it has to be straight. Patient has to look peripherally. If you bring it into the line of the visual axis of the patient, obviously he is then looking through the lens in the straight. So it has to be in the line of the visual axis of the examiner while patient is fixing eccentrically. Whether the head is turned or eye is turned is not important, but patient has to look eccentrically. The visual axis of the patient has to be eccentric while the examiner has to perpendicularly see that lens. Any intra-observer variation to be expected during peripheral refraction? Can we take the mean of the reading? Now see, I will give you a small and extremely very easy tip. When you do the central refraction, you tell the patient to look peripherally and just try to see, you neutralize in the center. Once you have neutralized in the center, you tell the patient to look peripherally and see if there is a width movement or not. Any width movement that you can see means that there has to be a refraction of at least plus 0.25 or plus 0.5. Any refraction of width movement when the patient is looking eccentrically and you are holding the lens in the center is peripheral hyperopia. Now, quantifying peripheral hyperopia, that it is plus 0.75 or plus 1, it has not been seen that if it is more peripheral hyperopia, there is more progression of myopia. Any amount of peripheral hyperopia more than 0.5 is significant enough. Now, do the patients on 0.01 or 0.03% atropine have changes in peripheral refraction like accommodative lag? See, accommodative lag is not from periphery. The simple thing is we do not accommodate eccentrically. We accommodate when the fovea is fixing. So whatever you do, whatever changes occur in the center will be reflected in periphery. There is no doubt about it because everything else remains same. Your apparatus of accommodation remains the same. So doing peripheral refraction with low concentration atropine does not change anything because peripheral refraction is not affected by atropine. Neither atropine is working on peripheral hyperopia or peripheral myopia. Now, that is what, so the seventh point, that any rate of change in peripheral refraction to be considered significant, I don't think there is.
Yellow.
Yes, Dr. Ankita. I don't think that the change in peripheral refraction has really been studied. There are two reasons for that. Number one reason is that they are not pretty sure what they are doing. So they are not really sure that this is exactly the 20 degree where they had done it last time. So there will be some variations when you are measuring, as in 0.5, I said, there will be some variations. What you want to see, you want to see whether it is on the plus side or not. If it is on the plus side, any reading on the plus side more than 0.5 is significant. Now, whether it will reduce or not, I don't think that peripheral refraction is really going to change much because it is an anatomical change and the change is very minimal. So even when the eyeball size grows, the peripheral refraction remains same because it is relative to the center. So it should not change. But I am personally not aware of work done on the rate of change of peripheral refraction. So I think we will have to discuss it again whether rate of change of peripheral refraction is significant enough or not. Now, in DIMS or HALT, in non-responders to atropine, should we add DIMS or replace with DIMS? I think we should add with DIMS, and there is no need to stop atropine because whatever atropine is doing, it is doing and it is creating dopamine. So the pathway of atropine and the pathway of DIMS or HALT are different. And so if low concentration atropine is being used then low concentration atropine is working symbiotically with DIMS. That is what we showed in a small work that we did. We did some work on combination therapy, and I think the next class will be on combination therapy, which I will be uploading. So I will be talking about how you should add to the how should you combine and not stop. So it is basically the two drops will the DIMS is not supplementary, which means that we should not remove atropine and start DIMS. It is complementary and they should be working together. So do DIMS and HALT work in pathological myopia? Not much is known about pathological myopia because the pathway of pathological myopia is thought to be different. But there is no harm in trying out DIMS and HALT. The problem is that DIMS and HALT uh, are not available beyond 12 diopters. So beyond 12 diopters, we will have to stop it there. And what is the maximum duration of DIMS and HALT use? 6 years. The data is available for last 6 years. So that is probably the maximum duration for which DIMS and HALT has been used. The company doesn't recommend that you can use only for 2 years or only for 3 years, because as such DIMS and HALT are not creating any change in the sense that there are no drops or no pharmacological interventions. So the only thing that they are doing is they are creating a myopic defocus compared to vis-a-vis the hyperopic defocus, which is already there. So there is no upper limit of duration of DIMS or HALT. Currently, 6 to 7 years of experience is available, and DIMS and HALT have been used for 5 to 6 years, and they have been working fine in those times. So that was regarding the questions. If there are any counter questions on that, I think we can take them. Dr. Shalaka, Dr. Aval.
Sir, in your YouTube lesson, sir, you said that in the of audience and all, you said that if the power is more, there will be a greater shift. In the
If
end,
the
you would
power is
mention there
more,
will be a greater shift and there will be greater progression. I didn't understand that point, sir.
no, I didn't get what you said. What did I say? If the power is greater in the sense, where will be the power will be greater mean?
Sir, in your sir, in
In my
the
lecture.
Dims and Halt YouTube session, sir, in the end, towards the end, you mentioned that in patients who have a higher power, higher amount of myopia, sir, in that there will be greater shift in the peripheral defocus segments, and hence that might lead to greater progression, sir. I didn't understand that concept, sir.
No, what I was trying to say was that if you're so in HALT lenses, if you're probably this was what I was trying to explain, and I will go back and listen to the lecture again what I meant to say. But what I was trying to say was that in the HALT lenses, if you see the rings, the power of the rings changes depending on what is the central power.
Okay,
So
sir.
So probably that is what I meant, that the change in the power of the, and I will go back and listen to the talk again. But what I meant was that what I probably meant was that in the central power, the rings will have a variable power depending on what the central power is. Now this is true mainly for HALT and not for DIMS, because DIMS has a fixed power of 3.5. So you just, if you can message me what in the timeline, what time I am talking about it, I will go back and listen to it again.
Okay. Oh, I'll send you the this line verbatim, as well as I'll send you the timestamp of the videos.
Yes, sure.
Thank you.
Any other questions? Do you have any other questions, Shalaka, on the answers that I have sent, or rather I spoke?
Sir, I just wanted to ask, with dims and halts, sir, do you see any rebound, or there is no rebound seen with myopia control glasses, sir?
So there are some reports. Honestly speaking, DIMS and HALT, at least in our practice, have started only 4 years back. So we don't really have patients except one patient in which we stopped DIMS mainly because he was already 18. So I was not expecting any rebound, and he did not have any rebound. So at this point of time, we just have 4 years of experience, and the company does say that there is no rebound, but in their reports, some of the patients have shown little bit of rebound, but otherwise there is no serious rebound as we have in atropine.
Sir, also, if we have to shift the patient which you shifted from myopia control glasses, whom you shifted to single vision lenses, sir, did he have any trouble adjusting to those single vision lenses?
No. Single vision lenses are much better. No, their field will improve. Normally, they don't have trouble shifting.
Okay, sir. Thank you, sir.
Dr. Jaswant, if you have any question.
Sir, it's a nice presentation. In fact, I don't know much about this field. I'm just learning what all we should learn.
Sure. Dr. Ankita, you had a question?
Yeah, so I wanted to ask at minimum age of even 3 or 4 years also can we start the lenses, these DIMS or Hall?
See, you can start at 4 years of age also. The only issue with this thing is that you should have a data suggesting that it is axial progression. So it is very difficult to have axial length reliably under 3 or 3.5 years of age. So when we plan to start it at 4 years of age, the records of 3.5 years are not available, that there is an actual axial elongation. So that is the only reason. If you have proper records that there is actually an axial elongation and not, there is nothing else, you can obviously start them on glasses. I have seen some of the patients or some of the doctors, anecdotally starting. I'm not saying that, you can't do that. The problem is very peculiar. Once you start them on DIMS or HALT, and if their progression is there or if their progression is not there, you are absolutely clueless whether this particular progression was there before or not. So that creates a problem, because it is like, I keep saying, it is like glaucoma drops. You have no clue, no idea whether your drops are working or the pressure was more, or whether if you have a patient, it is like ocular hypertensive. You have a patient whose pressure is 24. Now disc is pristine, there is no problem. There is a 0.1 CD ratio, and you have not done OCT, you have not done fields. Now there is no way for you to know whether this particular pressure is normal for this patient and whether it is creating a progressive optic neuropathy or not. So what happens is that your treatment response is not known, whether it is the glasses which have halted the progression, or they were not going to progress anyways, and it was just a physiological spurt of growth at that age. So that's the reason, if you have axial length in your hand, at least you have a fair idea that what exactly you are treating. So
Right.
there are some instances where, there are some of our colleagues, the moment a myopic patient comes, they feel good. Now, we can start them on glasses, and they do start them on glasses, and still there is progression. Now, we don't know whether, this progression is similar to before, or the progression is actually less and glasses are working, and the progression has gone down, and so that we should wait for another 6 months, or we should start them on atropine, because we don't know the previous progression was how much and whether it was because axial or not. I saw your question, Aval. Actually, Shalaka asked the same thing. When you change from DIMS and HALT to single vision glasses, patients are actually very comfortable. They don't complain. They really don't complain that they have been shifted from peripheral defocus lenses to single vision lenses. They are more than happy. So yeah, that's what I answered that question. If there are any other questions, please let me know. Fair enough. So if there are no questions, we can close the meeting. The next talk will be sent on combination therapy. And since the combination therapy is nothing but optical therapy, atropine, and mix and match of that, we have already talked about red light therapy. It is not available right now in the country. So we can, just talk about combination therapy, and then we can see how to set up a myopia clinic. I will upload that presentation also, and then we can have a joint meeting on that. Also, I would be dispatching the peripheral refraction aid that we have made. So if you can send me your addresses, I will be able to do that. So please send your address either on my personal WhatsApp or on the group. I will collect this thing and send you. And in the next Zoom meeting, we will also talk about. I will be sending you the video how to set it up and how to use it for peripheral refraction. You can do some. You can use it, and then we can discuss it and talk about how to set it up, how to actually do a peripheral refraction. Although the video that I sent does show it, but nevertheless, I will send another video where I will show you how to really use it. So that was regarding optical options and also about